That's good. My first introduction wasn't that great, so we're gonna do it again. It's my honor to introduce Dr. Cristine Velazco. Dr. Velazco is a board-certified general surgeon, and she is currently in her second to last month of fellowship here at Phoenix Children's in pediatric surgery. She's an assistant professor at the Mayo Clinic College of Medicine. She completed a master's degree in anatomy and neurobiology at Virginia Commonwealth University, and then earned her medical degree at the University of Vermont College of Medicine. She completed her general surgery training at the Mayo Clinic, Arizona, which is where we first got a chance to meet her and see what an outstanding surgical resident and pediatric surgeon she would be. She also did additional training and received a research fellowship at Harvard University at Boston Children's Hospital, working at the Center for Advanced Intestinal Rehabilitation on short gut syndrome. And then she also worked with the Vermont Oxford Network. She did an additional colorectal fellowship at Cincinnati Children's just prior to the year of starting her pediatric surgery training here in Phoenix. She's a member of the Mayo Clinic Clinical Education Committee, which is both Arizona and their tri-state committee. And then after completing her colorectal fellowship at Cincinnati, came to Phoenix Children's, where she started her pediatric surgery fellowship. She has written numerous peer-reviewed publications and book chapters. She's a member of the APSA program committee, which is very prestigious. It's a lot of work, but also very prestigious, and also a member of the APSA wellness committee. After graduating from our fellowship here, she is taking a position at the Arnold Palmer Children's Hospital in Orlando, Florida, where she will also be the director of colorectal surgery. With that, Dr. Velazco.
Thank you, Dr. Nutrica. So today I'll be talking about bowel management, and we'll be seeing lots of x-rays of stool. I have no disclosures, but I have looked at a lot of x-rays of poop during my colorectal fellowship. Here was a poop emoji at Mardi Gras, which was a simpler time in February of 2020, which turns out was COVID Mardi Gras. So we'll talk about bowel management, how we do it, surgical options for bowel management, as well as adjuncts to bowel management. We'll look at what a bowel management program looks like and do some interactive case studies that I'll ask for participation from the audience, and then look at outcomes. So bowel management is a method to keep a patient clean or socially continent. It's an individual plan to keep a patient clean in their underwear using enemas, laxatives, diet, and other medications. Each bowel management program is tailored to meet a patient's individual needs based on the age of the patient, their underlying diagnosis, and the potential for bowel control. Just because a patient doesn't have potential for bowel control does not mean they can't be clean with the use of a bowel management program. So basic principles of every program include every patient needing a different regimen based on their colon and their baseline continence, anatomy, and control. Abdominal x-rays are used to tailor each regimen based on the amount and distribution of stool. The goal is to keep a patient artificially clean for 24 hours a day. So who needs bowel management? Patients who have a history of anal rectal malformations, Hirschsprung's disease, spinal conditions such as spina bifida, patients with a history of pelvic tumors such as sacrococcygeal teratomas, or patients with functional or idiopathic constipation. So who has the potential for bowel control? Patients who are of potty training age, who have normal anatomy, such as that they have an intact dentate line and anal canal, they have anal sphincters, a normal sacral anatomy, which correlates with the development of muscle and nerves of the pelvis, normal spinal anatomy, where they don't have tethered cord, and normal innervation of the anal rectum. And then patients who have had an anoplasty that is within the sphincter complex without stricture or prolapse. However, again, this does not mean that even if you don't have these things, you can't have an effective bowel management program with these. Some people might recognize this book of Everyone Poops, but in this case, some people do it easier than others. So Evaluation of a patient prior to a bowel management week or program. Typically, we get a contrast enema without a bowel prep to see what their colon looks like. We get an x-ray of their sacrum and lumbar spine. We do kidney ultrasounds to see if they have any urological symptoms or abnormalities. We do an MRI of the pelvis if they were born with complex malformations, as well as spine, again, to rule out tethered cord or other problems. And then we can do motility testing, which is a whole other topic that I would defer to our expert, Dr. Medina, which I recognize is a very important aspect, but I am by no means the expert here in that. So here at Phoenix Children's, we don't really use the sacral ratio that much, but it does tell us about how the pelvic muscles may be developed, and a lot of other programs do use it. So the sacral ratio correlates with the development of pelvic muscles, and if it's hypodeveloped, then sphincter muscles and nerves can also be. And so in this example here, the ratio is 0.73, which is within normal range between 0.7 and 1. So they would, in theory, have be able to have good bowel control based on this. So we have various options for bowel management, including dietary, where we can enhance constipation, which seems counterintuitive, and bulk stool with pectin or insoluble fiber. You can use enemas using glycerin or soap suds like Castile soap, laxatives using senna or biscuitol, anti-diarrheals, which also probably seems very counterintuitive, which we'll talk about more later, and then bile acid sequestrants such as cholestyramine. So in terms of fiber, we give patients soluble fiber, which can be pectin, which you just get over the counter and at the grocery store, which binds water and forms bulkier stools and helps the patient have a sensation of stool in the rectal vault. Insoluble fibers such as Citracel or Metamucil doesn't absorb water, but has the capacity to bind with bile acid. It can make stool soft, and however, if the stool becomes too soft, then you can lose the ability to feel it and again have accidents. These can be mixed in foods like yogurt, applesauce, or with a small amount of fluid. Typical dose is 1 tablespoon with meals, but can be adjusted for the patient's individual needs. So when we look at enemas, most of the time we're talking about large volume enemas, where we use saline, which can be written as a prescription, or it can be made at home with 1.5 teaspoons of table salt in 1,000 milliliters of tap water. It's really important to stress to patients that or patients' families that this is a teaspoon and not a tablespoon, because you can cause electrolyte abnormalities if it's mixed wrong. Glycerin is typically used with 99% or higher, and you can get it, as you can see here, even at Amazon, and it's relatively cheap, $30 for a gallon. We use, on average, around 40 mLs, give or take, depending on the patient each time they have an enema. And then you can add Castile soap, which will increase the effectiveness of an enema. However, there are rare reports of development of detergent colitis or proctitis. I've never seen this personally. So when we're talking about enemas, a good place to start is 20 cc's per kilo of fluid, and then you add some glycerin. And here you can see this chart was from our fellows colorectal course this year, where they talk about starting with about 10 mLs of glycerin with a max dose of 30. I personally, from my experience in fellowship, disagree with that amount. I think you can go above that safely, but it is a good place to start. I typically would start a little bit higher than 10 mLs. Castile soap, where the biscuitol can be added if needed for an additional irritant, and you can also add fleets, but again, with the phosphorus, you need to be careful for electrolyte abnormalities. Typically, a patient is going to be sitting on the toilet for about 45 minutes during this process. Laxatives can also be used for a bowel management program using senna, which causes irritation of the colonic wall and induces fluid secretion and colonic contraction. Biscuitol is a contact laxative which increases fluid and sodium secretion and stimulates the enteric nerves that cause colonic mass movements. This graph here is taken from the Cincinnati Children's Bowel Management booklet that is given to parents. Krista, you can pass around those things to the audience in person. So it's important to see that all laxatives are not created equal, where each brand and each type is going to have a different milligrams. So it's important when you're talking to a family to know which one they're using so you can tailor the dose. In kids, we talk a lot about the X-Lac chocolate squares, and which is nice because the kids usually enjoy the taste of it and are willing to eat it. So anti-diarrheals can be used like Imodium or Lamodal for bulking and decreasing the frequency of stool, to then be used in conjunction with laxatives or enemas and prevent leakage in between bowel movements. So Antegrade Enemas can be used after a successful retrograde or traditional rectal enema is performed. And these include cecostomies, which are most common here at PCH, or appendicostomies, or if you don't know who this guy on the right is, it's post-Malone, but we call appendicostomies more commonly Malones. And so you need to consider if a patient has any concomitant urinary diagnoses before performing an appendicostomy. However, you can perform a split appendicostomy to share with urology, or you can create a neo-Malone where you actually create a catheterizable channel out of the cecum without having an appendix, or when urology needs it. I think it's really important to know the differences because patients may get surgical care elsewhere and then we care for them. For example, just last month we had a patient that we were seeing in the ICU who had a Malone. And the mom told me that I was the first person here that when I looked at the abdomen knew exactly where the antegrade enema should go, and that it was a Malone, where most people thought that his G-tube was actually a cecostomy, and they would frequently try and give him a flush through the G-tube. So we're more commonly see these here at PCH, cecostomy, where you bring up the cecum to the abdominal wall in a similar fashion to a G-tube. And you can see here a picture provided by Dr. Nutrico where we're tapping the cecum. And then you can put a mini ACE, which is similar to a G-tube, or a shape, and then provide the flush. Here, I made this video and presented it at IPEG about how to do a Malone, which we'll watch.
We present a single incision laparoscopic appendicostomy creation for antegrade flushes for bowel management. We start the procedure with a U incision along the inferior portion of the umbilicus. Next, the stalk is lifted up. The incision is extended slightly inferior and the fascia is incised and extended inferiorly below the skin to accommodate a 12 mm trocar. The abdomen is then insufflated. A 10 mm offset operating laparoscope is inserted into the abdomen. Using the laparoscope's working port, a 5 mm grasper is placed.
While this video is done,
The cecum and right colon are mobilized from their peritoneal attachments.
Type procedure.
After gently opening the peritoneal attachment, the cecum and right colon are mobilized anterior encephalad using careful blunt dissection in the avascular plane. Once adequate mobilization is achieved, the tip of the appendix is brought up to the level of the trocar and delivered externally as the trocar is removed. The fascial opening is then extended slightly to accommodate the cecum extracorporally. The tip of the appendix is then opened and an 8 French feeding tube is passed into the cecum. Using 2-O-ethylbond, the cecum is plicated around the appendix to create a valve mechanism. The cecum is then returned to the abdomen and fixed by suture to the abdominal wall. The appendix is then shortened to be flush with the skin edge. The fascia is closed, leaving a gentle space for the appendix to pass through without impingement. The appendix is then sutured to the umbilical skin in a VY fashion with fine absorbable sutures. The feeding tube is left in place and secured to the abdominal wall to ensure the tract remains patent and is used to begin flushes once the patient is tolerating a diet. The tube is left in place for a minimum of 4 weeks post-operatively. The patient returned to clinic and had healed well and is using the appendicostomy for antegrade flushes without difficulty. We present
was made by the patient. So, pros and cons of cecostomies and Malones are that a cecostomy can be performed via surgical, endoscopic, or radiology techniques. There is a somewhat higher leakage rate and granulation rate around the cecostomy tube itself, or stoma. Malones are catheterizable and cosmetically more appealing as they're hidden in the umbilicus, and after a period of time, patients, if they don't want to, don't have to have a tube in it and don't have to wear the little cap as you saw at the end of the video. However, strictures are more common and you can need to deal with those surgically or in interventional radiology. But I think one of the things I've learned most in my fellowship here at Phoenix Children's is about the importance of patient-shared decision-making and what's best for a family and patient. And I think that it's really important to offer patients options of and give them what's best for them. A study done about cecostomy and Malones did find that there were similar rates of bowel management success with both of them. So they're pretty equal in terms of patient success. So we can always offer whichever one is best for the patient. So some adjuncts to bowel management include pelvic floor therapy, some behavioral therapy for some patients develop a fear of stooling. Dr. Harris and I recently had a patient who we resected their sigmoid but was still holding with what we think was related to some fear of stooling after their long constipation history. You can use Botox to help with constipation as well as a sacral nerve stimulator. I learned how to do sacral nerve stimulators in Cincinnati, and these are transmitters that are placed subcutaneously in the upper buttock area and deliver electrical impulses to the sacral nerve. The technology is similar to a pacemaker, but can stimulate the bowel, sphincter, and bladder muscles for better control. They are MRI compatible. We typically do it in a 2-stage procedure where we place a temporary device for 2 to 4 weeks to see if it helps with bowel management, and then place a permanent battery pack, which is similar to a pacemaker battery in size. And then a remote control is given to the patient, the size of a phone, and it has Bluetooth technology. And I did not make this video, but just to show a little bit of how it's done. This is from the State Current app. This was made by Jason Frischer and my co-fellow before I got there and presented at APSA in 20.
Sacral neuromodulation is a therapy aimed at improving the quality of life of patients with constipation and fecal incontinence. By delivering electrical impulses through a probe placed near the sacral nerve, this technology acts like a pacemaker to promote bowel and sphincter function. Placement at our institution happens in a hybrid operating room equipped with a C-arm cone beam CT and a surgical navigation system. Using this technique enables us to offer this therapy to patients with dysplastic or malformed sacra whose anatomy would be otherwise prohibitive for traditional or purely fluoroscopic interventions. The patient is placed under general anesthesia and positioned prone with a pelvic roll for elevation and stabilization. A Foley catheter is inserted and grounding pads are applied. The surgical site is then prepped and draped in usual sterile fashion, with the drapes fastened under the bed to allow C-arm rotation and easy access to the patient's feet for electrode testing. Anatomical landmarks for the intervention are identified and confirmed fluoroscopically. The horizontal axis is marked at the posterior inferior iliac spine in the cranial aspect of the sciatic notch. The vertical axis are traced overlying the medial aspect of the S3 neural foramina bilaterally, roughly 2 centimeters from the midline. Using the ruled needle provided, conventional skin entry points are marked 2 centimeters cranially to these intersections. These would provide access to the S3 foramina at a 60-degree angle in the traditional approach without navigation. A cone beam CT run is acquired intraoperatively in a 3-dimensional model constructed for procedural guidance. The target anatomy is identified, and a virtual path is created from the skin surface to the desired electrode location and evaluated in multiple views.
You don't have to use this virtual path. You can just do
The virtual tip location is confirmed with the patient's intraoperative scan. The planned needle entry site is then marked with real-time image guidance. In this case, it was identified around 1 centimeter caudal to the traditional markings. The needle is inserted under live fluoroscopy to maintain proper angulation. The needle tip location is then confirmed with multimodal navigation. The proximity to the sacral nerve is assessed through electrical stimulation. A bellows contraction identifies proper placement at the S3 foramen with confirmation by plantar flexion of the great toe.
light contraction of
A guide wire is inserted, and position is again confirmed with imaging. Insertion of the neuromodulation lead is then accomplished with standard Seldinger technique, using the dilator sheath provided. Location is once again reassessed before removing the guide wire and dilator. The marker should be visible halfway through the foramen. A tined lead is then inserted under live visualization until the 3rd and 4th marks straddle the interior edge.
So after the lead's placed, it's connected to a temporary battery pack and tunneled subcutaneously, and then they use it for 2 to 4 weeks, and if it helps, then you implant it. I apologize to the Zoom audience that you're unable to hear the videos. That's the last one.
Yeah.
What?
They could hear it, they could see it.
Oh. All right. So another adjunct to bowel management are Cristine enemas, which can be done for patients by themselves, and this is an option if either antegrade surgical enemas aren't a possibility or not desired, and this allows the patient to administer them by inflating the balloon and instilling the irrigation on their own without the assistance of another person, which is nice for young teenagers and young adults. So here's a basic plan of bowel management for the different diseases. As you can see, there are many different pathways for it. If you have anal rectal malformations or Hirschsprung's disease, we like to check that you have the things that will set you up for success, such as an intact dentate line, that you don't have a stricture if you have Hirschsprung's disease, or if you have an anal rectal malformation, that your sphincter is within the muscle complex and you don't have prolapse or strictures. And if that's the case, then you can undergo a redo surgery before bowel management. If you do have not need any surgical redo surgery, then you can proceed with either laxative trials or enema trials. We say that a poor prognosis for bowel control you could start with enemas, but that doesn't mean that you'll never be able to get to laxatives. So we've talked about some of what goes into bowel management, but what does a bowel management week when you go to an institution look like? So in my experience, we would do this had bowel management weeks twice a month, and we would orient the patient and parents on Thursday before starting to the program where they would receive those booklets that are being passed around, and then they would have their preclinic workup with the contrast enema and any other adjuncts that need to be done, rectal biopsy, etc. Friday, they are seen in clinic where they see the surgeon, the colorectal nurses. That'll be their point person throughout the week, as well as child life. GIs sometimes sees the patient if needed, and then they have a weekend clean out where we try and get them clean after seeing what their contrast enema looks like. Because the most important thing to starting a successful bowel management week is getting them cleaned out to then continue on a regimen. So Monday we assess the stool burden after the clean out, and patients and parents start reporting their diary where they give us information. and then they're seen again on Friday, and then as needed changes when they go home. So the nurses receive daily calls and emails about times of voluntary bowel movements, times of accidents and soiling related to after they're given the laxative or the enema, and then they report types of bowel movements similar to what most of us know from medical school or from our practice of Bristol stools charts. So I'll go through a couple cases and then I'll ask for audience participation. So this is a 6-year-old female who had a vestibular fistula and no tethered cord and a normal sacral ratio. So in this case, we would expect her to likely be able to have good bowel control. So in this case, we would try laxatives. And so here, when you're looking at the x-ray, you're looking for how much stool burden there is. So you can see there's stool in the rectal vault on the left and stool on the right. We worry less about stool on the right because stool on the right colon is tomorrow's poop. Lots of poop. So we proceed with our disinfection over the weekend. And then on Monday, we start a regimen. Here, they elected to start with 3 squares. I should also mention that the colorectal nurses provided me with these slides from Cincinnati Children's, so I thank them for that. And Monday, they had patient had a voluntary bowel movement and then a smear. So they're going to need some kind of adjustment because they're not clean. So we get the next day's x-ray. Looks like you can still see some poop. Or sorry, no poop. And the x-ray's clean. We went up on, we had stayed at 3. We had 4 voluntary bowel movements and 1 accident. So probably in this case, we have overshot with 3, so we decreased to 2 squares. So the next day's x-ray also looks pretty clean. They had 5 to 6 bowel movements and then 2 accidents. So again, we need to decrease the number of laxatives with 2 chocolate squares. Following day, the x-rays still looking good. So we had 2 bowel movements but 1 accident. So in this case, they decided to add some fiber to both the stools. And then the following day, you see that we're actually starting to accumulate some stool. So but no accidents. So they left the patient on the same with 2 squares and the Citracel BID. And then they asked the patient to follow up in 1 week. And the way that they typically would have patients follow up is either if they're not able to send it through PowerShare, they would actually teach in the booklet, tells them how to actually take screenshots essentially of their own x-rays and email it to the nurses at Cincinnati or wherever you may be. So x-ray a week later looked pretty good, and so they left the patient on the regimen and had no changes. So this is a patient next that was an 8-year-old with an anal rectal malformation who had tethered cord and a sacral ratio that was decreased, so more indicative of possibly needing a having poor control. So they elected to start with, what do you think, Dr. Harris? Yes, enema. So as you can see here, there is a lot of stool on this x-ray and a really big colon. Dr. McMahon last night when I was going over my presentation while we were on call said they started with surgery. But this is bowel management, so we're not going to start with surgery, even though we're surgeons. So you can see that they needed to get disinfected over the weekend. They still had contrast left over and still a really large stool burden here. So then they started 400 cc's of normal saline and 30 of glycerin. So the next day, you can see there's still a fair amount of poop. So they ended up doing 2 enemas, 430. The next day, it's starting to get better, but not perfect. So then they added Castile soap to it for an additional irritant. The following day, we've still got this stool here. So we ended up going up again on the Castile soap and this time the glycerin as well. You also, when you're getting information from the families, want to find out if they're having any emesis or nausea related to this, because of it being an irritant, they can. And so you have to factor that in when you're making adjustments to the regimen. So then we see here we're getting better, but we still have some stool. So they left the amount the same, but asked the patient to try and increase their holding time before they evacuated the enema. Stool was not great, so this patient went up even more on Castile soap. So long-term plan for this patient, it might be that we end up doing surgery like Dr. McMahon said, but it's not necessarily where we would have to go. So I think it is worth a shot before just getting our scalpels out. All right. So then when we're adjusting the enema, things to think about are if a patient's having accidents 1 to 3 hours after an enema, and you see here that there's stool in the descending colon and rectum, then what would you want to do? Anybody? Increase. What? Increase the volume. Or you can make the additives stronger too. So then here, the x-ray looks pretty good, but they're having accidents throughout the day, but they're clean. So in this case, what do you think is going on? Speak up. Yes, so too much irritant. So you need to decrease the irritants. So get rid of some of the Castile soap or decrease the glycerin from 40 to 30. All right, so now everyone's up. If anyone from the Zoom audience has comments, maybe KVL, you can say them as well, okay?
Sure.
So I gave it away. This is our enema case, but what specifically about this x-ray do people notice? Exactly. Dr. Egan said there's an abnormal sacrum or no sacrum. So why would we want to start with enemas? How's the x-ray look otherwise? Sarah's shaking her head, not that terrible. Yeah. So here's our contrast enema. What do people think about it in terms of starting an enema? Do we want to do just fleet enemas? Do we want to do a saline enema? What do we want to do? Tiffany? Saline enemas, yes. So we want to do large volume with additives. Is there any way to minimize the thing at the top so I can see, so we can all see what this says? No. Where's our IT person? Thank you, Dr. Egan. All right. So the patient had no accidents after their contrast enema, and there's no way to minimize that, is there? This? Okay. But then I can't see this. Sorry about that, everyone. So contrast enema essentially clean the colon. So what do we want to? Let's pick a enema amount. Tara, what do you want to start with? Sorry, I'm going to pick on you. Okay. Yeah. So what for Zoom audience, what Tara's saying is that here they don't tell us how much contrast is used for the contrast enema, and typically You want to start the third or half of that, and so she'd like to get that added to our protocol. So let's just say we're going to do 400 for this patient. How much glycerin do you want to use? Okay, so we're going to start with 20. So after we give our 420, the patient has an accident 1 to 2 hours after the enema, and this is their x-ray. What do we think? Dr. Natriga?
Do they still have retained stool?
Yep, they still have retained stool in the rectum and the left colon. So what do you want to do to the 420? Yes, everyone in the audience is shaking their head and going up. And then anyone in the chat can chime in too.
Chat says less irritant.
Less irritant. Great. Thank you for participating. Oh, look, I got it to disappear. Perfect. All right. I don't know how I did that. We'll never see it again. So, yeah, so there's still some stool in the rectum and descending colon, as everyone has said in the audience. So, yeah, so we need a stronger enema. So, what do you want to go from 420 to what?
600.
Okay, and just 20?
40.
Okay. Yeah, so exactly. So if you just increase the saline, you're actually making the irritants weaker. So yeah, if you were to go up to 600, maybe a big jump, but yes, increase it and increase the irritant. And then, let's see. Thanks, Gabrielle.
So you increase it even though we had accidents.
Yes, because he's still got stool. So part of the problem could be that the reason he's had an accident is he still has stool. So Denise in the audience asked if we would still increase it even though he has had an accident. So we increased our enema to 640, which is a little more aggressive than I would be with the amount of fluid, but we'll do it for you, Notrika. So this time the patients had no accidents. What do we think of the x-ray? People are shaking their heads. Not great, but better.
Okay-ish.
Maybe better.
Better, but not perfect.
Okay-ish. Is that like being a little bit pregnant?
I don't see a baby on X-ray.
So, yeah, so it's okay-ish, as Dr. Notrika said, so we're going to keep it the same. Nope, that's the line, but thank you for seeing me. All right, so let's keep it the same, but there's still a little bit of poop. So this is the next day. What do we think? So still no accidents, but we kept it at 640. Dr. Harris says we need to shake it up in there. Is that like a high peck where we shake and bake? Okay. What else could we do instead of shake it? Soap? Sure. Let's add soap. How much do you want to add? Oh, yeah. Let's start with 9 ml, so 1 packet of Castile. So, yeah, exactly. Let's make it stronger. So we're 640 and 9 mLs of soap suds. All right. So we've increased it. What do we think of this x-ray? Yep, Dr. Harris is really proud of her work in the back of the audience. Yep, so we've gotten rid of the poop, so great. So we'll leave it the same. Good job. So, I mean, as you see, we'll do another case with laxatives, but it's basically, it's not rocket scientist, but it's tailoring it to patients, and it does take time. It's not just, start it at 420 and you're going to be good. And the next patient might look pretty similar and is going to need a different regimen. All right, so now we'll take a look at a laxative scenario. So this is a patient with idiopathic constipation who had their contrast enema on Thursday before the start of bowel management week. What do we think of this contrast enema? Can you describe it to me? What do you see, Tiffany? No. We are working on it, the audience says, but no, we do not, Dr. Williams, have a protocol outpatient at this point.
Okay, you announced the CME code too.
What?
You announced that CME code.
CME code for Dr. Notrika is 243719. All right. So, yes, Tiffany, we've got a dilated rectum, and then the contrast gets all the way into the small bowel. All right. So this is the day after, so Friday, when the patient comes to our clinic, and what do you think? What do you see on the X-ray, and then what should the plan be for the weekend in terms of chocolate squares? Brian, what's the X-ray look like to you? Yep. Does it look like soft poop or hard poop? Okay. I would argue it looks like hard ball poops, but yes, full of poop. So to get them clean for the weekend for the start of the laxatives, you want to disinfect with enemas.
Can you explain that? Like, how do you do it? Smart.
Yep, clean it. Thank you. It looks like little balls, and then if we go back to another, it looks more like soap sudsy. It looks like the actual balls, basically. So here, like on this, it doesn't look like little balls of poop.
Gas around.
And then there's gas also. You missed it, but we resected your colon, Dr.
Really?
McMahon. Yeah.
That's good.
All right, so yeah, so there's hard poop, so we disinfect with enemas for the weekend. So Monday, you get your starting X-ray, and they have a small voluntary bowel movement after the X-ray. What kind of dose do we want to start with? How many squares? 6, 1, 4. Dr. Notrika saying 4. So they said 3 squares, but either that's reasonable. So the X-ray is looking a little bit better, not as much of the hard poop. So the following day, they have 1 voluntary bowel movement and a smear in their underwear. And what changes would you make, and what are you seeing on the X-ray? Yeah, softer poop.
Still
Lots of poop on the left side, exactly. So we're on 3 squares right now. What do we think? Oops. Yeah, so they still got a large amount of poop, so give them an enema to try and get them cleaned out more and then increase. So we want them to do it around the same time, because then you're hoping that more or less not every patient has a bowel movement at 3 hours afterwards. So then especially once they're in school, you can say, like, I give them the laxative at 6 p.m. and then they poop at 6 a.m. Or they always poop 8 hours after, and if they want to be pooping not at school, then you time it for that. So it's not always perfect, but a lot of the time you can get to know the patient and how long it's going to take them to have a bowel movement from the laxative. So that's why it's important. And in the logs that Dr. Rose held up for the rest of the audience, well, you can keep that, not hold them up, like keep passing them around. You actually write down the time that they have the poop. You have to write the time they have the soil, and then what actually the consistency is.
You want to address the question?
Yeah, and so then Dr. Williams said, I do not hear a lot of discussion regarding go lightly cleanouts. Is that antiquated in the surgical world? Dr. Van Leeuwen commented that the lightly clean outs via NG are resource intensive, cost a lot, and insurance are not happy with the numbers, so we try to move away from them. Yes, I would agree with that. Occasionally we would get patients admitted for bowel cleanouts, but we never liked it when we had to do a bowel management week in the hospital. We try and keep this outpatient. And then Laura Wellner says that many patients with neurogenic bladder from SCI or neurological conditions causing paraplegia, quadriplegia can have successful bowel management programs with laxative and use of mini enema NMEs timed daily. I know you spoke a lot about acute clean out protocols and surgical antegrade enema programs for those patients without bowel control, timed NMEs and toileting. Yes, I agree. You can use antegrade, or as I mentioned, the Cristine enema once they're older. You could also do for patients, which is Cristine specifically tries to target that patient population as well. All right, so we've increased to 5 squares. Let's see what the next day's x-ray looks like. So that night they had a small voluntary bowel movement and a small accident overnight. How's their x-ray look? Yeah, looks better. Do you want to make any changes? All right. So someone's saying 1 less square. You could try that, or you can do no changes. Let's see what the audience said. Yes, PCH is working on a bowel management program, but no formal one yet. All right, so 5 squares, 4 squares, let's see. So next day, we have on Friday 2 voluntary bowel movements, and then after the x-ray, they had another bowel movement with no accidents. How's the x-ray look, and would you make any changes? Yeah, great. Keep it the same, Dr. Egan said. All right, so thank you, everyone, for participating in our game show, according to KBL. All right, so we've gone over how bowel management works, but does it work long term? So the Nationwide Children's Hospital performed a study looking at patients who had anal rectal malformation that attended their program over the course of 4 years. And at the start of their program, all the patients had soiling problem, and by 1 year, 70% of the patients were clean. And about 2/3 of the patients were on enema programs, and of those that were on programs, 75% were clean on their enemas at 1 year. The other 27% who were on laxatives, there were 62% that were continent with voluntary bowel movements and clean. They all reported, for the most part, an improvement in their pediatric quality of life score. And then we'll try and move this again. They did note that of the enemas, it was a split almost 50-50 of doing retrograde versus antegrade flushes in this group. So we have some studies that show that it does work, but does a bowel management program keep a patient out of the ER with constipation? So the University of Utah looked at this and did find that after their program, they found that the rate of ER admissions had significantly reduced by 82%. And this included both adherent and non-adherent patients, which I think is one of the big barriers to a successful bowel management program is adherence. So then Utah, again, worked this time with Nationwide in this study, and they did a 2-site study looking at ER visits, hospital admissions, and constipation-related morbidities such as abdominal pain, impaction, and UTIs before and after a bowel management program of patients. And so they found that 184 patients that were included, that the unplanned hospital admission rates decreased from 65 to 28, which was how did that happen? All right, sorry, the screen. Sorry about that, everyone. There was a 56% reduction in hospital admissions and a decrease in healthcare-related costs. Justin, I said that yes, role of motility is important. However, in terms of time restraints, I did not focus on motility as we have our own expert, Dr. Medina, here at PCH, and just commented on it. But yes, I agree that motility studies are an important adjunct to bowel management. So if we know that bowel management programs can keep kids out of the ER, how do we do that? And we found that it requires continued contact with the provider after the bowel management week. And long-term success rates of 1 and 2 years was 72 and 78% in a study reported by Kilpatrick and colleagues. And they also found that they had contact with 44% of patients after the fact. And this, you need to have a large, at least some personnel, if not a large number. In Cincinnati, we had, I think, 5 colorectal nurses dedicated to just colorectal and bowel management. And then you can also see that despite not coming to a full week, patients that were more successful did return more likely for follow-up visits than ones that were non-adherent. So we do see some barriers to bowel management programs. We have few programs that specialize in it. It requires a lot of work, as you can see, and there's not a lot of financial incentive in terms of reimbursement, as insurance doesn't reimburse great for it. And then we have patient barriers to accessing care in this, in that not every center has a established bowel management program, and a lot of kids may not be able to have the resources from their parents to travel to Cincinnati or Nationwide or Boston or DC in order to get this care, or Utah. So during COVID, we did see that virtual bowel management programs were feasible, and some places, when I looked in my search, such as Boston, do this, but it is for established patients only. And now that we've gone back to pre-COVID rules, you do need a license in that state. And so Nationwide Children's did look at this during COVID and offered a hybrid and telemedicine visits compared to a 7-day in-person bowel management program. And they found that at 1 and 3 month follow-up, they did have improvement in their continence scores and symptom scores. The biggest thing, I think, from this study was the parental satisfaction with the telemedicine option, that they didn't have to travel and stay far away from home for their bowel management weeks. They saved time and money in doing so. They were able to stay in their home environment and be more comfortable, and they felt like it was easier on their kids to implement regimens and give enemas or rectal irrigations at home and not in a hotel room when they had traveled. So in conclusion, care does not end after surgery for anal rectal malformations, Hirschsprung's disease, pelvic mass resections, and other patients. Bowel management programs require coordination of care even after a bowel management week for long-term success, with a patient-centered and patient-tailored approach that makes this key to success. And many hospitals and locations lack access to formal bowel management programs. However, telemedicine may aid in this disparity, but requires physicians to be able to get licenses in other states. We do not offer sacral nerve implants. And so I'd just like to thank everyone I learned from at Cincinnati, especially Jason Frischer, who was my program director, pictured here in his hat, and my co-fellow Iris, who I would not have gotten through the year without her, and then Monica Holder, who is one of the nurses who gave me all the bowel management slides to show to you today, and then all my mentors here at PCH, specifically my colorectal mentors, Dr. Van Leeuwen and Dr. McMahon, who have not only helped build on my experience from Cincinnati, but have helped me get on the national level with some Stay Current podcasts and supporting me in AMSA. So thank you, and I'll take any additional questions.
This is amazing, Christine. This is Kathy just kind of chiming in.
I think we have about 4 minutes for questions, and Dr. Van Leeuwen is helping us with the chat.
Yes, thank you, Dr. Grimsby. There are adult urologists, and I know at Mayo, one of the colorectal surgeons also does sacral nerve stimulators for fecal incontinence in adults.
So, when often when we do antegrade enema programs in kids, they're still seeing us when they're 30 and even 40 years old. So, at Cincinnati, what's their transition plan?
So Dr. Fisher, for example, does have privileges at University of Cincinnati, which in that case is very convenient as it's a walk across the campus, which makes it a little bit easier if he does need to go over there for a procedure, and he'll actually go help them in patients that are adults. I do think that you're absolutely correct. This is a big problem, not just in Phoenix, but across the country, and not just in colorectal, but in cardiac and all different diseases where kids are living longer and living till adulthood, and a lot of adult surgeons are inexperienced or sometimes unwilling to entertain this patient population. There is nationwide a unique situation where a physician ended up doing pediatric colorectal surgery and never ended up, unfortunately, matching into pediatric surgery, so she made it the best of both worlds and did then an adult colorectal fellowship and does adult transition to care, which I think would be an option for people to consider in the future, where they do both adult and pediatrics.
And then you mentioned that Cincinnati has 5 APPs that do
nurses, and then they have 2 APPs. So these are RNs. So they have the RNs are the ones who answer all the phone calls and then talk with the APPs and the surgeons. So during a bowel management week, there are these 5 colorectal surgeons, and every day at least one of them comes to the noon hour where we look at x-rays and with the nurses, and then the nurses report about the plan at home. So they had a bowel movement or they threw up from the enema, and they then are in contact with how to change it, or what prop they had trouble getting saline, or they the balloon broke on the Foley for the enema. So obviously they have a very large program, and not every program would need that many nurses because you're not going to have as many patients, but it is definitely labor intensive for a successful big program.
Did the study from Utah or nationwide, is that like after a bowel management week, or is that the overall program?
Yeah, so after a bowel management week, they looked at
And did that include kids
years.
with like anorectal malformation and first?
Yes, exactly. So this study was all comers, and then they also looked at both studies were all comers. So rectal malformation, Hirschsprung's, and other lesions. There was even, I think, in the combined study, a patient who had a problem traumatic gunshot wound. So all walks of life. Dr. Egan?
A lot of our patients that start having problems with toddlers and are not going to tolerate enemas at that age. At what age do you find that patients start tolerating enemas? And is there any kind of like therapy that's sometimes necessary to help them to start tolerating?
You're right. I think it's harder in small children. We talk about potty training age to be the very earliest as to when you could consider a bowel management program. Doesn't mean that it has to be then, or that it necessarily will work with enemas, but the youngest I've seen is about 3. That average age is usually around 6 for a successful program. But I think being able to sit on the toilet for enemas is also another big thing. You could, in theory, try and do it in a diaper, especially patients who have spina bifida or other problems. But I think you're right. It's harder in the very little kids when they're also trying to potty train. But I don't think it's necessarily impossible.
All right. I think we need to wrap up. I really appreciate the grand rounds. Learned a lot today. And if you have any additional questions, Dr. Velazco will be around for another 7 weeks. All right. Thanks, guys.
Thank you.